Well, the topic of my talk is treatment of infectious uveitis. What should be the considerations? So, treating infectious uveitis is a very important topic because, by and large, whenever you are in meetings or wherever, the emphasis is on making the diagnosis. You know, everybody tells you, you make the diagnosis of infection, rule out infection, and you feel very good when the diagnosis is made. But then there is another set of challenges which start once you have made the diagnosis of infectious uveitis. The first and the foremost is the treatment of infection. Are you going to give local antibiotic? Are you going to give systemic? What is the end point of the treatment? We don't even know. Anti-TB drugs, 6 months, 9 months, 12 months, 18 months, we have absolutely no clue. Then there is a question, like Manisha so elegantly showed, that even if you have a tubercular granuloma, give corticosteroids. So there is a problem. Are you going to treat concomitant inflammation as well as infection? Challenge of paradoxical worsening, especially in TB. There is a problem of drug resistance. And then there is also an issue of autoinflammation induced by infection, which is now we are seeing following COVID inflammation. So let's answer some of these questions one by one. The first is, how do you choose the route of antibiotics? We do understand the eye has blood retinal barriers, both inner and outer, which will not allow the adequate penetration of antibiotics in the eye. Therefore, if you give locally, they will definitely behave much better. However, there are certain infections which may be a part of the general infection in the body, and syphilis tops the list of those. In those cases, you do not want to give local antibiotics because you want to treat the rest of the body. So how do you go? You look at infectious uveitis. First see, is it the inflammation part of the systemic disease or it is just the local inflammation? If it is a part of systemic disease like syphilis, then of course systemic treatment. If it is a part only local disease, then again you have to see, is there any latent systemic disease which might have a chance of recurrence? And typical example is TB. When you do test for TB, they will not come positive or they will be equivocal and there will not be systemic infection of TB. But if you treat TB locally, like Manisha showed you very beautifully, she has been treating with granulomas with anti-VEGF and moxiflox. We have also treated them about 6 years ago. They do very well, but when you see them after 5 years, 6 years, they start coming back with other manifestations of TB. So though you are treating it locally, you may still have to give a very good systemic therapy to prevent recurrences. The other hand is a disease which is local. For example, there is a Duchenne or there might be cysticercus and you don't find it elsewhere in the body, or even toxo for that matter, which is by and large the local disease. You just treat it locally with antibiotics and they will work. Now this is an example of a systemic disease. Now this is the patient who comes, a 55-year-old man who is seen with bilateral visual loss of 3 weeks duration. You can see there is hypopyon, there is black arrows indicating posterior hypopyon, there is a diffuse leak on fluorescein, and then there are these yellowish lesions, and of course there is vitritis because of the media haze. So this is the patient where it has syphilis written all over it. So of course you do the general physical examination. He does have a maculopapular rash on the palms and multiple flesh-colored varicose nodules on these perineal area, which is suggestive of condylomata lata, seen in syphilis. MRI too shows lacunar infarct in the right corona radiata, suggestive of obliterative endarteritis. So the diagnosis is syphilis. He is also HIV positive, so he needs systemic therapy. So there is no point even thinking about the local therapy in such a scenario, because here the ocular inflammation is a part of the general systemic infection. This is how the patient is treated with antisyphilitic agents, and this is how the patient responds to therapy over a period of time. The second example is the systemic therapy. Systemic therapy you may not give because patient has systemic disease, patient has local disease, but that local disease is kind of triggered by systemic infection which is latent. It sounds complex, but very simple example. We again come back to TB. Now the patient has this serpiginous-like Corroditis. You test for TB, it's negative, but there is a mycobacterium sitting somewhere else in the body which is producing this immunogenic phenomena in the eye. So this, if you give injection steroid locally or whatever, it will respond. But since you have not taken care of that bug sitting somewhere else in the body, you will have a recurrent course. So for that reason, you will have to give anti-TB drugs. So this becomes the second scenario, that you treat the systemic therapy for systemic diseases which needs to be addressed. And this serpiginous-like Corroditis is a prime example. Now you see, this is the patient seen elsewhere, serpiginous-like Corroditis. Montius was 12. Anti-TB treatment was not given, X-ray was normal. He was treated with steroids and he did respond. You can see the healing here. And this picture is taken 3 months later. What happened 8 months later? So this is when now the patient comes back and you can see this whole yellowish kind of a granuloma kind of a thing sitting there. If we had, treated it with anti-TB at this point of time, we could have prevented the development of a granuloma formation like this. So this is 8 months later. We hunted for TB in the body. She just came up with the history that she had parotid Warthin's tumor. So when we did the PET scan, there was an activity in the parotid gland. We got her slides and reviewed them. It was actually a tuberculosis of the parotid gland. So the moral of the story is that please always do not let your pulmonologist bully you in telling you that it's not a pulmonary TB, because it won't be. Court study has shown that pulmonary TB is not seen in 92% of the patients with ocular TB. That bug, wherever it is sitting, might be producing recurrences, so you have to treat it. Got to treat it. Sorry. Now we come to third example where you may have to combine systemic with local therapy. Now this is a 47-year-old lady. She comes to us, decreased vision in the left eye of 10 days duration. And you see retinitis, which is diffuse, and it's no-brainer that it is a viral retinopathy that we are dealing with. So this is when she presents, February 2021. We give her IV valacyclovir, steroids, aspirin, the usual work, and the patient develops acute tubular necrosis because of antivirals. So the dose of valacyclovir is reduced to half, but it's not working for her. Now this is the time when we have to supplement it with the local therapy, which was intravitreal injection of ganciclovir given bi-weekly. 2 milligram, 0.1 ml was added, and this is how finally the patient responds to therapy. You may argue, why not give only local injection? Because you have to give acyclovir to prevent the development of ARN in the opposite eye. So these are the balances that you will have to keep. Simply because she is developing acute tubular necrosis, you cannot make her blind. So please work with your nephrologist to give a minimal dose to prevent the opposite eye and supplement this eye with the local therapy so that, you are taking care of both. The fourth example is the local therapy only, which is kind of controversial, but which does work. And when it works very well. That is toxoplasmosis. So this is the example of a patient decreased vision in the left eye of 4 days. Unilateral, this is the first episode. You can see it's a retinitis lesion, which is very typical for toxoplasma. And patient receives injection of Clinda-Dexa, and you can monitor the response to therapy in 2 injections. So we are not talking about toxo in particular, but local therapy can be used, especially if the disease is not recurrent. However, if the toxo is recurring again and again, you may have to add systemic prophylaxis, which is actually Septron every 3 days for 20 months. The second point is, what would be the end point of the treatment? How long are you going to give? So we, per se, for ocular disease or ocular infections, we really do not have endpoints defined. What we do is what our infectious disease or our internists do for the systemic disease. Like for ocular syphilis, we treat it like neurosyphilis and we give treatment for 2 weeks. Then there are diseases like acute retinal necrosis, where we have a very well-defined protocol. So there is no need to remember the doses and the protocols for these antibiotics, but when you are starting the patient on this treatment, please make sure the patient has a complete protocol followed. Don't leave it, after 3-4 days simply because patient is feeling better or you don't want to give. So the protocol should be followed, whatever treatment we are giving. However, there are certain diseases like viral anterior uveitis. The systemic treatment with antivirals may be given for prolonged duration, which needs to be customized as per patient. The third point is, which is a very important point, is how would you treat the concomitant inflammation? Inflammation, we know, can destroy ocular structures, so you need to give corticosteroids, but please refrain from injecting into the eye if you are suspecting infection, because you cannot take it out. Even if you are giving oral, fine, it's infectious, you can always reduce the dose, you can stop if something happens, but if you have injected in the eye, it will be very difficult to retract that back. Now this is an example of a patient. He was seen by the primary doctor like this. It looks a very classical toxo. The doctor got confused with, I don't know with what, but treated with corticosteroids and with anti-TB drugs. And then he thought the steroids were not working, so he also injected Subtenon, Kenacort, and this is what the patient had. A simple toxo turned into kind of a diffuse toxo simply because of the mistake in making the diagnosis first. And secondly, if you're not sure of the diagnosis, at least don't keep on pushing steroids, because toxo has a tendency to heal naturally. So maybe if the patient was not treated, he might have done actually better. The toxo might have just gone away. But by giving it steroids, we made the matters much worse. This is another example of the patient. Large TB abscess, multibacillary disease, and you see this was caused by the Ozurdex. The Ozurdex was injected into the eye and that resulted in the rampant spread of this. The fourth issue is when you start anti-infective treatment, there could be paradoxical worsening, and paradoxical worsening is something which happens very commonly in TB. For example, you start anti-TB drugs and the bottom one shows the worsening of the previous lesion, development of the new lesions as in arrowheads. So these are the examples of paradoxical worsening, which typically comes in 2 to 3 weeks' time when you start anti-TB drugs. The result is the release of cytokines, which is producing and the treatment is corticosteroid, which could be local or which could be systemic. Since paradoxical worsening is mostly seen in immunogenic form of TB, here giving the corticosteroid systemically or even locally would be okay. The drug resistance is not very common, and I won't go into much details about it, and this is typically characteristic only about TB. The sixth one, which is very complex and not for comprehensive ophthalmologist, again, I would not touch it. So to conclude, it's very important to initiate timely specific therapy for infectious uveitis, but please note you cannot wash away your hands simply because you have told your internist कि इसको syphilis का treatment दे दो, इसको TB का treatment दे दो. This is not how it is going to work. There will be lots of issues which are going to come up when you start the patient on anti-infective therapy, and many a times you will have to intervene either with local or with systemic steroids, immunosuppressions, and what all. So that all will become a very important part of your day-to-day management. So thank you very much for your very patient hearing, and so we now continue with this session, and we have our next speaker. Is Dr. Neeta here? Okay. We have our next speaker, Dr. Jyotirmay Biswas. There is some mix-up here. We are doing 2 sessions together because all our speakers were busy elsewhere. But now Dr. Biswas, Chief of Uveitis Services at Shankara Nethralaya, Chennai, is going to give 2 talks back-to-back, one from the last session and one from this session. And that will be followed by IUSG talk by Dr. Aniruddha Agarwal from Abu Dhabi.
So, Aras, this is on. Thank you, Dr. Bishali. For I was held up with that oration. They put me on the last oration. So, this is the very short talk, Pulse of Uveitis, which I want to share with you. I just want to share with you a few cases. This is a 30-year-old female, immunocompetent, and fundus had got this kind of whitish lesion with necrotizing lesions with hemorrhages over the posterior pole. What could be the diagnosis? So you can make a morphologic diagnosis of necrotizing retinitis, but the etiological diagnosis, if you look carefully at the patient as a whole, you can find that there is a herpes zoster vesicles over the forehead. And in fact, this patient has got varicose zoster retinitis, atypical type posterior pole, and after intravenous acyclovir therapy based on the clinical examination, the patient showed a marked resolution of inflammation. So looking at the patient as a whole, in addition to the slit lamp and indirect ophthalmoscope, is of great importance. Case 2, this is a case referred from Mumbai, 43, nothing else is that one 43-year-old male, dimness of vision and floaters, diagnosed as CMV retinitis. He was HIV positive and he was treated with intravenous ganciclovir. I shake hands with all patients before the COVID era, of course, all patients routinely. I found something wrong in his hands. And what I found, there is the hand was rough and there is a scaly lesions over that one rash. And then that made me no difficulty in finding the diagnosis when I found the subretinal precipitates with exudative retinal detachment. It was a syphilitic retinitis, RPR and TPHA came positive, treated with intravascular injection of penicillin, and after treatment everything resolved. It was an accidental finding, I agree, but you should have a prepared mind. Case 3 is a 47-year-old gentleman, pain, redness and swelling for 2 months, diagnosed as tumor with intraocular extension. Advised radiation and brachytherapy, referred to our institute for the same. When I looked at that one, I found something different. It doesn't look like to be a tumor. And though there is an, I did ultrasound to see that there is an intraocular extension was there or not. Ultrasound biomicroscopy showed homogeneous mass arising from the episcleral sclera. We did that workup for the autoimmune scleritis, all are negative. So RA negative. But we did that, we had a suspicion, we did that last thing, that VDRL and TPHA, which came positive. And after intramuscular injection of benzathine penicillin, the patient responded remarkably. We published it. Sometimes you need to think out of the box. Case 4 is a 30-year-old Indian male. He was diagnosed in USA as serpiginous choroiditis, metamorphosia in both eyes. He had the choroidal lesion with the geographic border, but it doesn't look like to be that typical yellowish white color. It was a little pinkish in color, which made me suspicion that whether we are dealing with something different. I did ultrasound and I found there is a high reflective lesions were there, and CT scan confirmed further diagnosis that this was not a serpiginous choroiditis, it was choroidal osteoma. Always keep an open mind. Don't be carried away by the diagnosis the patient is carrying, bringing with him. Case 5 is a painless gradual dimness of vision, 9 months. The patient is from Delhi actually, and was diagnosed as tubercular choroiditis. He was put on anti-tubercular treatment for 6 months, and I thought that these lesions doesn't look like tubercular choroiditis. Is no pigmentation was seen. There is a leopard skin spots like seen was there. I talked with our oncologist, ocular oncologist, and we did a fine needle aspiration biopsy, and my suspicion was corrected that there was a large amount of necrosis, and within the necrotic tissues large lymphoma cells were seen. 6 months after patient developed CNS lymphoma. Be mindful. Case 6 is 35-year-old male, dimness of vision 1 month, diagnosed as choroiditis, treated with high-dose oral prednisolone. Is it choroiditis? As we do all suspected choroiditis, fundus fluorescence angiogram, and I found not to a surprise that it was a multiple leak CSR, showing my pinpoint leak and with pulling of the dye in the late phase. So always do FFA in all cases of active choroiditis. Last case, this is I made a mistake. 15-year-old girl, sudden blurring of vision right eye, vision counting finger at 50 centimeter, diffuse KP studded over the cornea. I thought that this is a pan-uveitis due to the TV or sarcoid. And in fact, I couldn't see the fundus very well because due to that lot of anterior segment and vitreous haze. I did ACTAP for PCR for MTV and it came positive. I thought that I am seeing a case of tubercular pan-uveitis. But when that vitritis or anterior segment cleared up, I looked at the vitreous and it was a typical toxoplasma retinochoroiditis with spillover anterior uveitis. I didn't do the ELISA for the toxoplasma as an anterior uveitis case. That was a mistake. I was misguided with the PCR. So after 33 years of uveitis practice, I'm still learning, I'm still being pulled by many uveitis cases.
Thank you very much, sir. Any questions for Dr. Biswas related or unrelated? Anything? Okay. You want to break, then Anirudh can present, and yeah. So we move on to IUSG session. I discussed about the treatment and the challenges, and it's really my proud privilege to have Anirudh Agarwal. Anirudh is one of the youngest members of International Uveitis Study Group, and he's traveled all the way from Abu Dhabi. He's working in Cleveland Clinic, Abu Dhabi right now. So Anirudh is going to talk about local therapy in uveitis, when and how.
Very good evening, everyone. Thank you very much to Vishali ma'am for this kind opportunity, and thank you AIOS. So I will be talking about local therapies in uveitis, when and how, and often it becomes very important for all of us managing patients with even systemic steroids, immunosuppression, to probably add on local agents, and it becomes very important for us to understand exactly what are the indications, techniques, and outcomes. We all know the hallmark of uveitis is inflammation of the posterior segment, especially that's what mostly concerns us all. because these patients can often develop inflammatory cystoid macular edema. Apart from that, they can have other manifestations, which we all have seen beautiful photographs from the previous talks. There could be vitritis, choroidal thickening, and other inflammatory manifestations. Now, two important entities that can happen are retinal vasculitis and neovascularization. We all know the issues with systemic steroids, because many patients, they require extended treatments with systemic steroids and immunosuppression, which all of which increase the risks of complications such as reactivation of TB and other adverse effects such as derangement of metabolic profile, secondary infections, and abnormal blood counts. It's our goal always to preserve vision in patients of uveitis by decreasing the level of vitritis, and also it's the cystoid macular edema. Of course, all the established guidelines talk about early treatment, and our goal eventually in patients who have chronic disease is to reduce corticosteroids to at least less than 10 milligram per day. So with adjunctive therapy, especially intravitreal and local therapies, we can actually reduce the long-term need for steroids. Now, before I tell you when to use local steroids, it's very important for us to understand when not to use steroids or any other local therapy for that matter. So we've had some case examples where Dr. Vishali ma'am beautifully showed us that if you do not know the diagnosis, do not inject, whether you're injecting in the intravitreal or in the periocular space. Now, for infections, very much beware. Rule out all infections before injecting steroids or any immunosuppressives. Of course, if it is an infection due to toxo and you want to go ahead with Clinda and Dexa, it's fine. But no Ozurdex or long-acting steroids in such cases till your diagnosis is clear. Now, as a general rule, if your media is not clear, if you cannot see the entire fundus, so if there is a severe vitritis or a cataract, do not inject unless you see the complete retina, because you may have a patient of a chronic uveitis, but there is a concomitant acute retinal necrosis sitting somewhere in the corner. So you don't want to miss that. Also in patients with exudative detachments, choroidal detachments, low IOP, the reason is not known, or if there is of course any ocular contraindication, we generally do not inject. And when can you do local therapies? And I'll show you some case examples. You can do local therapies in patients where you want to use local as an adjunct to your systemic treatment, and this could be for the treatment of choroiditis, cystoid macular edema, retinal vasculitis, and panuveitis, or if there is a suboptimal response to systemic treatment, or if there are contraindications and certain specific conditions such as lymphoma, or if you have a patient of immune recovery uveitis where you can potentially use local or intravitreal therapies. Now, of course, neovascularization requires anti-VEGF, and certain infections like viral retinitis requires sometimes adjunctive ganciclovir, but I will not be discussing those two aspects. So most commonly, the agents that we use intravitreally are methotrexate and Ozurdex. Of course, now sirolimus is available. We have adalimumab, infliximab, and also fluocinolone implant, which has been recently FDA approved. Anti-VEGF and antibiotics are available, and Dr. Manisha ma'am is currently, I think, doing a study on the intravitreal use of anti-TB medication. So there are lots of drugs in the pipeline, really, but methotrexate and Ozurdex are the most important ones. Now, methotrexate initially was used for lymphoma, but now the indications of use of intravitreal methotrexate have expanded. It's a very useful adjunct, has no side effects such as rise in IOP or cataract. Of course, it can cause corneal epitheliopathy, but usually there is no retinal or choroidal toxicity. So there are a number of studies which have used methotrexate intravitreally as an adjunct. And looking at this patient here, now this is a child who came with macular choroditis lesions. Now, some of these patients, I had the privilege of learning from Dr. Vishali when I was in PGI and managing them with her. So this is a young girl who had 636 vision. The MON2 was negative, quantiferon negative, and the CT scan was negative. So you can see this patient, of course, she received oral corticosteroids, and because the lesions were macular and we were reasonably very sure that this is no infection, this is definitely not syphilis like the ones showed us, or toxoplasmosis, so we treated with a concomitant intravitreal methotrexate. And you can see here that the OCT angiography shows you the characteristic hyporeflectivity, the autofluorescence shows you hyperautofluorescence in the center. And so along with intravitreal methotrexate, this patient did very well. And at 6 weeks, you can see the autofluorescence is completely clear. And what impressed me most was that the RP was completely intact on autofluorescence. And the OCT again, it shows you complete normalization of all the layers. The OCT angiography, of course, always shows you something, and at 6 weeks it shows you there is some disturbance in choriocapillaries, but of course we may not give it so much significance. The patient is happy and the disease is healed. So the ultimate word is that methotrexate works great. The only problem with methotrexate that we have is it works for a short time. So intravitreal Ozurdex is one agent that could be used longer, and CME becomes an important indication for Ozurdex. So if you have a patient of, let's say, intermediate uveitis with cystoid macular edema, or if it's a posterior uveitis which is non-infective, you can go ahead with the Ozurdex implant. And we've done a study as well in which we analyzed the use of Ozurdex in TB uveitis as well. So we realized that the vitritis and cystoid macular edema and the leakage on fluorescein associated with intermediate, all of this can be taken care of by an Ozurdex implant. So of course we prefer it in unilateral disease, but if it is a bilateral disease, let's say one eye is worse, you can add an adjunct of an Ozurdex along with systemic treatment. There are some patients of choroiditis. Now this is not a classical example, but you will find some patients who, despite systemic corticosteroids, have some amount of hyperautofluorescence on their autofluorescence imaging. And this is probably a residual disease which does not take care of by corticosteroids alone. Usually in our clinical practice, we rarely like to go beyond 60 milligram per day of prednisolone. Beyond 60 milligrams, studies have shown that it's not safe. So going up to 70, 80, especially in heavy patients, is not the preferred practice. So in such patients, you can go ahead with the Ozurdex implant. But please make sure you're dealing with only and only choroiditis and not an infection. So this was a publication of the use in TB uveitis. And of course, this is the blown up ICG image where you can look at the choriocapillaries hyporeflectivity or loss of choriocapillaries in patients of choroiditis. And if you are treating with an adjunct corticosteroid, we realize that if you keep the area of flow deficit less than 0.1 millimeter, these patients, they have minimum disturbance in the flow void areas. So like this patient, for example, this patient healed very well over a period of 6 weeks. And in fact, we did a pilot clinical trial of using corticosteroid systemic along with an adjunct Ozurdex and systemic steroids alone. And we realized that the pattern of healing on OCT angiography and visual acuity are much better if you can add an Ozurdex at baseline. So this is the comparison at the flow deficit area on OCT angiography, and the patients who are in arm with the intravitreal Ozurdex, they did much better. Now I'd like to show you this one patient. This is an Indian girl who came to me in Abu Dhabi with multifocal choroditis. This patient was heavy, had other systemic issues, and again, like I said, I did not start the patient on more than 60 milligrams corticosteroids. And you see the autofluorescence in the left eye was particularly concerning because you have lesions which are very close to the center. So of course this patient was started on steroids, and in addition I counseled her for oral the intravitreal Ozurdex, and at the same time I rapidly tapered the oral corticosteroids. So it was like 10 milligrams every 3 days after the injection. And within 2 weeks I found that some of the lesions, especially if you see this near the superior arcade, have actually gone away. So if you see this particular lesion, is not even there at 2 weeks follow-up. And this is at 4 weeks. Now at 4 weeks, this patient is completely off oral corticosteroids and almost everything has healed. And of course, the Ozurdex is still going to act. So Ozurdex works very well in choriocapillaritis, especially if you have a sort of a multifocal choroditis, even placoid, TB. It works very well with reasonable adverse events that we all expect. But remember to rule out infection. This is one Somalian patient who came to me just 2 weeks ago, and she was diagnosed with scleritis and exudative retinal detachment. She was given corticosteroids. Because there was no improvement, someone injected Ozurdex, and now there's a scleral melt in the area of scleritis, and this patient actually had a Pseudomonas aeruginosa endophthalmitis. So if you're not sure, there can be catastrophic complications with Ozurdex. I'll just take 1 minute more. This is an agent. Of course, we always compare triamcinolone with Ozurdex, and the POINT trial was recently conducted, which showed that intravitreal triamcinolone works as well as Ozurdex. Of course, the duration of action is less, But personally, triamcinolone, I do not prefer in my practice because of the higher chances of glaucoma and cataract. It's very useful for cystoid macular edema in intermediate uveitis. The MUST trial also talked about fluocinolone implant. Now, the Iluvien has been recently FDA approved for non-infectious uveitis, but I do not have a happy experience because, one, it's not as effective as Ozurdex, and two, it does not last really very long. It doesn't last more than 9 to 12 months. Like the company claims it's 36 months, I think that's not true. Intravitreal infliximab has been used. Now, it has been used since 2010. It's not new. Systemically, it works great. It's FDA approved. But there are significant concerns with regards to retinal toxicity. So there are a number of immunogenic and retinotoxic effects with intravitreal infliximab. In fact, in 2021, this study was in patients of Behçet's, where they showed that intravitreal infliximab was associated with a high complication rate. So it should not be a substitute for systemic infliximab or biological agents. So methotrexate, sirolimus, we have number of agents. Sirolimus, of course, is not so much marketed in India, not so much preferred. The efficacy is much less. Intravitreal adalimumab is an option which is coming up. There are very few studies, however, to support its use. But of course, we have methotrexate and Ozurdex, and if these agents are used judiciously, they can work wonders. So thank you very much, and I'll be happy to take any questions.
Thank you very much, Anirudh, for opening up an entirely new area of treating non-infectious uveitis with local injections. So any questions from the house? I have a question for you. Like, one girl you showed was methotrexate you treated, and you said it's a short-acting one.
Yes.
So if required, what would be your limit for giving local injections?
Methotrexate, even Mark Desmet's paper, if you see, where he is used in methotrexate in TB uveitis, usually if it's a macular lesion, we give one injection. If necessary, we repeat at 2 weeks. But usually the mean number of injections is not more than 2 or 3 maximum. So if you need more, then of course prefer a longer agent like Ozurdex. But otherwise, not more than 2 is usually necessary.
Okay. Yes, Mudit, please. There's a mic.
The other point, advantage of methotrexate is also it's a very safe drug. So even if you're giving it intravitreally, like what our experience has been with lymphomas, people have given multiple number of injections. The initial induction dose actually is like 2 injections every week for 4 weeks.
Yeah.
Then you go on for a consolidation and a maintenance. So for lymphoma patients, end up getting 10, 12, 15, even 16 injections of methotrexate without a problem. So that is probably another advantage of methotrexate, that it's a very safe drug.
And very cheap.
And very cheap, yeah.
It's very cheap.
Yeah,
One thing I'd just like to add, like if you have we had a patient, ma'am would remember, of viral uveitis, and these patients sometimes, once the virus is healed, they can develop CME, which is non-resolving, and they may benefit with intravitreal methotrexate without the risk of really reactivation of the virus.
Yeah, exactly.
I have got a patient of intermediate uveitis who had depression and as well as the glaucoma. So only option I had that give intravitreal methotrexate, and she is quite happy. She wanted the injection in other eye also, so I gave that injection in other eye.
Yeah. So any questions related to treatment part of posterior and pan before we move on to anterior uveitis by Dr. Biswas? Well, if there are none, since we started the session quite early, so this is actually the last talk of the session by Dr. Biswas. He is going to give you pearls for managing anterior uveitis.
So, anterior uveitis would have been fast, but it has become the last, but it's not so simple. So let us look into some cases. This is a 30-year-old man, pain, redness and photophobia.
Said this is the last talk. You can make it interactive and ask everybody.
Okay.
You can take
How do you
a little
approach?
quiz.
How do you approach it? My approach would be I look into the history and history. Is it the first episode? Is there a recurrence? So recurrent anterior uveitis, how is the previous response to treatment? The patient says that it responded to the treatment with the steroid earlier. Is there any low backache? These are my first questions. Is that one? Is the hypopion mobile? I'll do HLA-B27 first. I will not go to the syphilis test or anything like toxo or not. I'll do HLA-B27 first. But this is a patient where I will do a lot of investigations, like 30-year-old man, not much pain, not much redness, and you can see multiple Martin fat keratic precipitates. So what test will do? I'll test for the TB and sarcoid first, Mantoux quantiferon TB gold test, X-ray chest, HRCT chest, serum AC. Even I'll do an VDRL and TPHA. If all negative, I'll go for PCR for MTB, though there is a lot of doubt has been raised, but in our hand it works quite well. Go for PCR for MTB, and in this particular case, MPB64 was positive. This is a 59-year-old man, had chronic uveitis with pigmented KPs, IOP 40 mm mercury. What is the diagnosis and what test will do? I will make it interactive.
Yes. Posner-Schlossman. Who said that? Wow.
Correct. This patient, what test I will do? I will suspect viral anterior uveitis. And as the virus cannot be seen in direct smear or culture, I will do PCR for AC-TAP for HSV1, HSV2, VZB and CMB, both nested and real time. And here real time PCR for HSV1 was positive, and it actually became negative after the treatment. This is a 20-year-old man, no pain, redness, floater, fine keratic precipitates all over the posterior surface of the cornea. How many of you will investigate? And what investigations you will do?
So the question is, you are sitting in your clinic, you see this 20-year-old man, no pain, no pain, no redness, no floaters, and you have this picture. What is so characteristic here? No posterior synecdoche.
No posterior synecdoche.
You know?
Disproportionate cataract.
Fuchs.
This is actually Fuchs uveitis. Can have associated raised IOP. No need to worry, no need to investigate, no need of steroid before cataract surgery, gratifying results with phaco and IOL. This is a 25-year-old female, blurring of vision and floaters. Just don't forget to focus behind the lens for anterior vitreous cells and debris. This was an intermediate uveitis. When you did the indirect ophthalmoscopy, you could see the exudates in the vitreous inferiorly. This is a 21-year-old female, had raised IOP, acute anterior uveitis, immunocompetent, KP small to large, vitreous cells. So don't forget to examine the fundus. We did that. We did not do that initially, but later on, as soon as the things cleared up, the pressure became all right. We looked at the fundus and we could find that the patient had actually had acute retinal necrosis, wedge-shaped peripheral retinitis lesion. So if we have waited lost one more day, it would have been progressed to the posterior pole. This is an 8-year-old girl, joint pain and swelling in the right knee, no pain and redness of the eyes, referred by rheumatologist. What is the possible diagnosis?
Come on.
GIA. When we saw the eyes, we found there is a posterior synecdoche already developed. There is a band-shaped keratopathy, early band-shaped keratopathy. It was juvenile idiopathic arthritis associated uveitis. Most common childhood rheumatic disease, most prevalent systemic disorder in children with uveitis. This, of course, is little unusual. 16-year-old boy, recurrent attack of pain, redness and blurring of vision, had history of recurrent fever with systemic hypertension. 16-year-old boy had having systemic hypertension. And this was the reason the patient ultimately underwent renal biopsy, acute interstitial nephritis. Urinary beta-2 microglobulin was elevated. And this is I asked the patient to bring the biopsy slide. He looked at the slide and took photograph, and you could see that the tubules, surrounding the tubules, there is a chronic inflammatory cells was there. This is an acute interstitial nephritis. The patient had non-granulomatous antiuveitis both eyes. I treated with not only topical steroid, I put the patients on oral mycophenolate and prednisolone along with the nephrologist, and these become all right. This is a tubulo-interstitial nephritis associated uveitis. We are more and more recognizing nowadays than before. This is the 8-year-old boy, history of joint pain and skin rash, pain and redness in both eyes. And you can see the skin rash was there. This is a maculopapular dermal rash. And the patient had keratic precipitate with Busakas nodule. What is your diagnosis?
Say loud. Leprosy.
No.
Sarcoidosis.
So a kind of sarcoidosis, a pediatric sarcoidosis, this is called Bloch syndrome. After treatment with my adalimumab, the patient is responded. This is a Bloch syndrome. This is a 7-year-old female, persistent hypopyon uveitis, not responding to the topical and systemic steroid. This is a very, you don't see this kind of hypopyon in the extremes of age. Hypopyon, if you see, you is not responding to the topical steroid, no fibrin, you would be thinking of muscular syndrome. And here is the situation where you can do that anti-chamber tap and pathologists can diagnose as retinoblastoma. So how do you manage it? Topical steroid with short-acting mediatic cycloplegic agent is the mainstay of therapy. Anti-uveitis is responds very well, is magical sometimes. This is a fibrinous anti-uveitis before treatment, and 1-hourly topical steroid with mediatic cycloplegic agents. In 3 days it got cleared up. So topical steroid used in which one to choose? Earlier we used to use the betamethasone, but now we have switched over to prednisolone acetate for several years. It has biphasic solubility allowing to penetrate both the lipid and aqueous layer efficiently. So, but you need to shake the bottle before use. I even use every 15 minutes initial few hours, every half hour, but minimum every 1 hour. Taper gradually by 6 to 8 weeks and may continue for some more time, maybe 1 time a week, 1 time a day, and for several weeks. Fluorometholone is quite effective in chronic anterior uveitis. I use it sometimes when that topical steroid, the patient is having glaucoma more. So FML is sometimes useful to prevent the spike of anti-uveitis. Soft steroid can be used, loteprednol, but there is no role in acute anterior uveitis. Less chance of risk of IOP rise. NSID, I give that patients with GIA when it's completely under control. Sometimes I put the patients on long-term non-steroidal anti-inflammatory agents. Mediatic and cycloplegic, which one to choose depends on the degree of the severity. In majority of the cases, somatropin 3 times daily is suitable. People stay mobile. Atropine I use in the fibrinous anterior uveitis for few days. So this is the algorithm: topical steroids, mediatic cycloplegic agent, not responding systemic steroid, and non-responding you think of something different, and some other etiology, masquerade and etc. you should think, and whether there is any posterior uveitis is present, and if not responding you really need to do that one. You can add immunosuppressive agents. Immunosuppressive agents is usually not required in anterior uveitis. Recalcitrant cases, GIA with anterior uveitis, methotrexate is my first option. Anterior uveitis with bases, VKH and sympathetic ophthalmia, I always add systemic immunosuppressive agents. This is a question, $1,000,000 question. Can you prevent recurrence of anterior uveitis? I got this article, methotrexate an option for preventing recurrence of acute anterior uveitis. This came from England. iJournal is published. They found the recurrence rate pre-methotrexate 3.4. It comes down to 0.89 per year. But if my patient is in my city, I tell him that why to use methotrexate for 3 months? You can easily come to see me. But the patients who has got outside and have got multiple recurrences really bothered. I tried with methotrexate, it works. So take a good uveitis oriented history, which I want to highlight. Don't forget to look at the patient as a whole. Do tailored laboratory investigation based on clinical differential diagnosis. I prefer HRCT chest in granulomatous uveitis than X-ray chest. Start with frequent topical steroid and taper as per response. Always do an indirect ophthalmoscopy with scleral depression. And finally, don't think anterior uveitis is so simple.
Thank you, sir. With this, I would like to invite Manisha, Anirudh, Rima, and Padma Malini to stage, and we will have quick pearls for comprehensive ophthalmologists in the clinical scenarios. Please come. I will conduct. Sir, we start with you. We have young people sitting here. Mudit, please join. We do have young people sitting here. Suppose they see a patient with acute anterior uveitis, Dr. Biswas, sir. It's a non-granulomatous form of anterior uveitis. What do they do?
I think non-granular, I'll look for history. I think I should go for a history first. If the patient tells that it comes about 7-8 times per year and every time it responds with that topical steroid, I will suspect HLA-B 27 times. They do understand. Some people are so intelligent. They say that the eye becomes heavy, then they find that the light is hurting it, and then 2 days after, within the pain, redness, photophobia, blood redness all starts.
Manisha, what would be your take on anterior granulomatous uveitis that comes to your clinic? Like somebody's seen treatment naive patient, new patient, they are seeing granulomas. What should they do? How would they proceed?
So, first of all, we'll have to do a thorough ocular examination, rule out that there is no involvement of the posterior segment.
That is very important. So when we say anterior uveitis, we assume you have dilated and seen the posterior segment, which is normal, only then label it as anterior uveitis. Thank you. Yeah, go on. Sorry.
So I think that is something very important. And then subsequent to that, of course, you'll have to do some tailored base investigations to rule out that there is any systemic granulomatous disease in that patient. And when I say that, I'm going to go ahead and do a complete hemogram. I will do HRCT to have any evidence of a granulomatous disease, and of course do a Mantoux test.
Okay. So once you have done these tests, so primarily when you are seeing granulomatous form of this, and to this I would also add that when you see granulomatous anterior uveitis, commonly like Manisha said, it could be TB, sarcoid, and thirdly it could be viral. So look at the IOP. If the IOP is high, it's more likely to be viral. If IOP is low or normal, then as Manisha said, you will proceed. Now this brings us to the question, what if Dr. Biswas showed a beautiful case of Posner-Schlossman syndrome? So I would go to Mudit. Mudit, what will make you suspect viral anterior uveitis? Because to my mind, the herpes anterior uveitis has really gone up, and Padma Malini is here. We will come to her next. Post-COVID, we are really seeing an increased number of patients of viral anterior uveitis due to herpes. How would you suspect it so that, these patients are not treated wrongly?
Yeah. So 2 clues. First is the distribution of corrective precipitates. So multiple fine stellate KPs. 2 differentials usually are either a Fuchs or viral uveitis. So if you see multiple fine KPs spread all over, then that again plus an elevated IOP. So you see these 2 things in conjunction. My first diagnosis then shifts towards that being a viral uveitis. Apart from that, again a history. So like you take a history, if the patient gives a history of either a COVID infection or even a prior vaccination, that in itself again probably can be a clue. So history of an infection, prior vaccination, and the distribution of corrective precipitates plus an elevated IOP. All of these put together usually will probably tend to shift the needle more in the direction of a viral uveitis.
So, Dr. Padma, you have a lot of experience. You made us put a session on COVID in IUSG. We've taken. So, what is your experience of viral anterior uveitis in the post-COVID era?
So we have seen
This mic.
Post-COVID, we have seen lot of viral reactivation, especially the varicella zoster virus, presenting in the form of episcleritis, scleritis, anterior uveitis. We also have seen cases of acute retinal necrosis. Varicella zoster virus was the commonest. We have seen few herpes simplex reactivation, not even the recurrence happening for the first time, and few CMV anterior uveitis cases.
So, Dr. Rima, like we are talking about viral and Fuchs, you brought a very important issue that many a times Fuchs patients are diagnosed as intermediate uveitis. Can you put riders towards the vitreous involvement in Fuchs and how would you manage it?
So the Fuchs is typically, as we have read all these years, is unilateral, but we are seeing now bilateral. So mostly these cases are unilateral. You have the KPs before you go to the vitreous. You have the distribution of the KPs, which are very characteristic. Then no synecdoche and cataract. If you're seeing in the early stage, it may not be there or may be there. So coming to the vitreous, we have floaters, we have dense vitreous membranes. And if you have a confusion whether you are dealing with the unilateral intermediate uveitis, look at the inferior fundus periphery. If you find snowballs, then you rule out Fuchs. If you find none, go for OCT. You have CME, you're dealing with intermediate uveitis, and then we do a fluorescein angiography. No CME, Fuchs. So, and then you again come back to your anterior segment, look at the iris pattern. If you have not dilated, you can have different pattern of the iris as you compare with the fellow eye. So you know that heterochromia is not so prominent in Indian eyes, but many of these eyes can give you a clue when you compare it with the other non-dilated iris of the other eye.
So we would come across, all of us come across patient of Fuchs who do have flare and 1 or 2 cells here and there, and of course KPs. And many of them are already on topical steroids. Would you start steroids if you see cells?
I tell the patients that this is a smoldering chronic infection. You're likely to bear with this and just live with it, because they have 1 to 2 plus cells, and giving steroids, sometimes they just end up with high IOPs. So you're not adding anything to the benefit of the patient, but you're making the disease worsen. So we tell them that the problem of floaters and mild haze would persist, and they get rid of it by the time they develop the cataract and get cataract surgery. So it's easy to counsel them.
So Anirudh, now that we are at the treatment, Dr. Biswas has beautifully shown the treatment of anterior uveitis, where he showed steroids and then not so strong steroids and then non-steroidal anti-inflammatory drugs. So my question to you before that is, how would you manage viral anterior uveitis?
So in viral, I think the first step that we all should do, if possible, if you have resources, try to get a PCR. If you don't have a facility, try to find out if somebody can do the PCR for you, because it becomes very important to distinguish herpes, varicella and CMV. If it is herpes, the treatment is simple. You give oral. If it's a viral anterior uveitis, you would give oral acyclovir or valacyclovir. Of course, we prefer valacyclovir. You can give 500 3 times a day oral with tapering after 4 to 6 weeks. And topically, we would give corticosteroids topical. There is no role usually of topical ganciclovir gel in herpes or varicella, but definitely a role in CMV. If you feel it's a varicella, then you will like to give full dose acyclovir, which is 1 gram 3 times a day, or acyclovir 805 times a day for 4 to 6 weeks. If it is CMV, the treatment is completely different. It is 900 milligrams twice a day of ganciclovir. With you can reduce it to 900 once a day after 4 weeks. Remember that all viruses, they tend to recur. 80% is the recurrence rate. So they will all need prophylaxis dose, which is probably 500 once a day of valacyclovir for as long as possible. There is no guideline on how much to give, but any episodes of flare cells should be treated topically with steroids and cycloplegics if there is pain. and of course the oral antiviral.
Thank you. So from anterior, now we move on to intermediate, and my question to Dr. Biswas, please. Dr. Biswas, a comprehensive ophthalmologist sees a patient. There are some vitreous cells, there are some snowballs inferiorly. So how should they proceed?
If they are fluent, if they are quite conversant with indirect ophthalmoscopy, they should go for a good indirect ophthalmoscopy and use a scleral depressor. And nowadays with the optos photography is available with that one, I will ask him to get an, if he has got some other reason optos with them, go and get an optos done. It will show the exudates much more clearly. And first I would like to see in the slit lamp itself, in the vitreous cells, the number of coarse vitreous cells, if you see, that will indicate the possibility we are dealing with an intermediate uveitis. And in such cases, the treatment part of it is different. The graded approach is if it is a unilateral, and after explaining the patient with the risk of glaucoma, I try to give the posterior subtenon injection if there is no other etiology is found. If etiology is found, then I treat with the oral tablet. Most of the times now I give that immunomodulatory medications straight away. The reason is that they are always a chronic disease. So my way of going for a mycophenolate mofetil plus steroid in the bilateral intermediate uveitis.
So Dr. Manisha, for the same patient, what would be the lab investigations that would order?
So for intermediate uveitis, I think the most important would be that I like to rule out any underlying infectious etiology, and especially tuberculosis again, which is very common in our part of the globe. And again, the investigations which I think we've all described since we have been having this session. And once we are sure that we are not dealing with any kind of an infectious etiology, then of course the treatment is going to remain as steroids and immunosuppressants.
So Mudit, how common would you look for multiple sclerosis and get a MRI done in a patient with intermediate uveitis?
So usually it's not something which we get done in the initial onset, but like what Dr. Manisha had said, and like what we have discussed throughout the session, I usually get some tests done routinely for all of my patients. I get a etiology check for syphilis and HIV for all of our patients, and also TB. The reason is not only because of the fact that you are suspecting this disease, but also because subsequently you may have a need to put these patients on long-term immunosuppression, and therefore it makes sense to get these tests done. At the initial onset, I usually do not get a MRI done for multiple sclerosis, but if the patient gives any history which is suggestive of any neurological deficit or any neurological features, or in cases where there are multiple episodes recalcitrant treatment, in those cases we have gone ahead and got an MRI done.
So Dr. Anirudh, where will you start treating them systemically versus local treatment? Like Dr. Biswas said, he would prefer MMF for bilateral cases. And what is your take on treating, and for how long would you treat intermediate uveitis of idiopathic origin?
So the intermediate uveitis of idiopathic we traditionally call pars planitis. There are few indications of treatment. One is if there is definitely cystoid macular edema, or if there is severe vitritis or peripheral vasculitis. So in such instances, we go by the rule, if it's bilateral, we generally prefer systemic. And of course, initial bridge by corticosteroids followed by immunosuppression. You could choose azathioprine or MMF. And we usually go, once we start, in the first episode, we like to give it at least for 1 to 2 years. And if it's a recurrent disease, we would probably give it for as long as possible. In unilateral cases, often I supplement with the intravitreal implant. And in those cases, once you have done the implant, often you may need 1 or 2 implants, and you may not need long-term corticosteroid or immunosuppression. So I think it's very important for us to assess the disease periodically by getting a fluorescein angiography, because that is the only valid clinical endpoint really in intermediate uveitis to look at the level of inflammation. So I think angiography and OCT help you as parameters to look at the disease activity.
Dr. Rima, is there any situation you will do a therapeutic vitrectomy for patients with intermediate uveitis?
As a primary modality?
As primary, in between, before immunosuppression, after, whatever.
Yeah, so if the vitritis is dense, we compare it with the other eye, or even if it is bilateral. So if there are significant vitreous membranes which are precluding your complete examination, you're not happy with the fundus examination, I would do in those cases. And where we suspect some kind of malignancy or masquerade, or if it's an elderly patient presenting with vitritis or intermediate uveitis, to rule out PVR.
And I think it's very important what Anirudh said and Rima said. Many of these snowballs and membranes will not go away with steroids and immunosuppression. So please don't take them as a marker of activity, because they are going to stay. The marker of activity would be how much is the leakage on fluorescein. So if you are pushing more steroids simply because they are snowballs inferiorly, and if it is bothering you or the patient, only way to take them out is vitrectomy, which we are not discussing here. But only point is the inflammation is to be monitored on fluorescein.
Ma'am, may I add a comment to this?
Of course.
So, as we were discussing Fuchs, I think it is the most over-treated entity with steroids. When the patients present, they are already having cataract and glaucoma. And the other spectrum is intermediate uveitis, and this is the most undertreated, I think, entity. When we have patients, they are presenting with vitreous hemorrhage, they are presenting with peripheral tractional detachments at times, and this is because the inflammation has not been properly controlled and the duration of treatment has been inadequate. And we have patients presenting with anterior, like peripheral hyaloid proliferation, causing neovascularization, causing vitreous hemorrhage and tractional retinal detachment. So I think we have to keep in mind that intermediate uveitis needs adequate treatment and a long-term treatment.
Thank you. So from intermediate, now we move on to posterior uveitis, and my questions goes to Dr. Padma Malini. You are the imaging person here. Now you have a patient with focal retinitis in the posterior pole. It's a young patient. How would you go on imaging and before doing the labs? What imaging would you prefer? Because every day in conferences we hear multimodal imaging, this imaging, and I think this is the time we talk about customized imaging rather than customized labs. Everybody can't have everything. So
posterior uveitis is focal retinitis. We would like to get the optical coherence tomography or an OCT. It is a non-invasive imaging modality. We will find characteristic findings such as posterior vitreous cells and oval-shaped deposits in the vitreoretinal interface, and it could be a retinocorroditis. In case of toxoplasmosis, we will have full thickness retinitis, associated choroidal involvement. So all these things goes in favor of toxoplasmosis. How do we differentiate this from a viral retinitis? In viral retinitis, also we'll have depends upon the etiology, we will have either the inner retinal, outer retinal or full thickness involvement, and commonly the choroid is not involved in case of viral retinitis.
So that's a very important point. I think these days we are all relying very heavily on OCT to look at two things. One, is it retinitis? Is it choroiditis? Is it retinochoroiditis? Or is it chorioretinitis? So that will help you in making the differential diagnosis very well. Dr. Anirudh, now that people are not really having true color fundus images because most of our new cameras are on pseudo imaging, pseudo color. So what is your take on how reliable is pseudo color imaging for uveitis?
So if you are depending on either Spectralis for pseudo color, Spectralis has a multicolor option. Optos also is pseudo color. There are many other cameras which have pseudo color. The problem comes in uveitis, not so much in medical retina, because in uveitis we have recently published that a lot of lesions appear different. Their colors are completely different on multicolor, and they may appear green, they may appear pigmented. The pigmentation may be mistaken for hemorrhage, and these are common issues. So if you are just depending on photos, you will miss out. Some of the cameras, they have individual color channels like blue or green channel, which are there in spectralis, and individual color channels in Optos. Some of these channels, they completely do not show choroiditis, especially if it's a new lesion of choroiditis. So what we have learned in our recent study was that you cannot really depend on multicolor imaging for either diagnosing or follow up any posterior uveitis. You need to have a clinical examination or a true color fundus photo.
Dr. Biswas, now while the time the patient, we have seen a patient of retinitis, done OCT, realized it is retinitis, what would you do? Investigations lab.
Yeah, investigation lab, I would do first toxo.
You would first. Would you, if you think it's toxo, would you order any lab?
See, if it is I'll think toxo, and I'll start the treatment if it is a high suspicion.
So you will not wait for the lab results. That's very, very important. If you think it's toxo, and we come to the viral just after this, Mudit is going to answer. But if you think it is toxo, you don't wait for the lab. You don't have to do labs. Why
but
wait?
But not responding, then I look for syphilis and viral retinitis.
So you can straight away start treatment. So Mudit, it's a diffuse peripheral retinitis, looks like on. What would you do, your protocol?
All right. So again, like what you said for toxo, again same, you don't have to wait for the lab results to come. The good thing about infectious retinitis or infectious involvement of the posterior segment is that a lot of times it's a matter of pattern recognition. A lot of these diseases have a characteristic pattern. Like what we discussed earlier, a unifocal retinitis most of the times will turn out to be toxo. So you don't have to resort to waiting for the labs. You do have to get the labs done, but you don't have to wait for them to start your treatment. Number two is the importance of appropriate antimicrobials. Giving steroids becomes a disaster unless and until you've got an appropriate antimicrobial. So I may probably not start steroids, but the antimicrobials can be started immediately. So like it was toxo, you will probably start with a Bactrim DS or Clinda or whatever you want to. Same for viral. If you have seen a picture which is characteristic of an acute retinal necrosis, then you may probably go ahead and straight away start them on a Valacivir, which is what we usually do end up starting them with. And the initial induction dose is 2 grams 3 times a day for 2 weeks. Then you subsequently shift to 1 gram TID for the next 6 to 8 weeks. And then you can maintain them for some time. At least you should maintain them on treatment for 6 months, because that is the duration till which there is a risk of the ARN occurring also in the other eye. But while you have started them on treatment, at the same time I do, like I said, get an HIV and a TPHA or syphilis done for every single patient of mine. Even for toxoplasmosis, some of times these patients who have been thought of as a viral retinitis turn out to be toxo, because toxo behaves in a very atypical manner in immunosuppressed patients. So as a rule, I get a HIV and a TPHA and a CBP done for all of my patients, but I don't wait for those results to start my treatment. The other point is, lot of times we give valganciclovir for our HIV patients or for patients with CMV retinitis or viral retinitis. It is also imperative to get a CBP or a blood picture done before we start Valgan, because valganciclovir is known to sometimes cause a myelosuppression. Therefore, before starting valganciclovir, I also get a CBP done. But those are the points which I keep in mind.
So Dr. Reema, is there any situation you would like to do PCR for viral posterior uveitis? Or like Mudit and Dr. Viswas says, will it be purely clinical all the time?
It's mostly clinical. Unless the patient is not responding to treatment, I think that is the case we'll do. But generally not required for posterior uveitis.
So the basic message is that for posterior uveitis, especially if you are thinking about toxo or viral, you really do not, if the phenotype is so characteristic, please start the treatment, because you don't have luxury of time to wait for the lab results. Patient might lose eye, and antiviral is fine. Even if later on you realize it was not virus, just stop it, but the treatment has to be started in time. So now moving on to the last leg of this thing is pan-uveitis. So Manisha, what would be your approach to a patient who has a pan-uveitis and comes to you?
So I think pan-uveitis, I think history taking is going to be extremely important. I would surely like to know any kind of a systemic association with the presence of ocular inflammation. And that surely needs a very detailed history taking. Of course, a systemic evaluation again, because you can have certain very subtle signs which can convey the reason for ocular inflammation, like we have been seeing, like syphilis. Dr. Biswas showed that you can have lesions on the skin, you can have lesions in the palm. So I think all that has to be paid a due attention. And then based upon what kind of signs you are getting in the panuveitis picture, you are going to do a tailored based investigations, or a tailored approach to the lab investigations. And again, I think that is seeing to the overall profile. I don't think there's a very generalized lab investigations which we order, but it is going to be based on the clinical profile or the clinical picture of the patient.
Now, one very common mistake which we all learn from books is that we think sympathetic and VKH are pan-uveitis. Dr. Biswas, would you like to tell youngsters how to recognize VKH in its very early form of the disease before it becomes pan-uveitis?
So VKH, many of the patients will give a history of headache, and their disc looks hyperemic, and secondary retinal detachment. And if you have got an ultrasound is there's a choroidal thickening will be the first sign. You need not to go for an OCT in all cases. If you don't have OCT facility, you can do a simple ultrasound and see the diffuse choroidal thickening involving the posterior pole, which will give you the clue that you are getting that VKH. Unilateral VKH is very uncommon. If you see once a bilateral choroidal thickening, no vitreous haze significant, and you should give an option of suspicion of VKH.
So Padma Malini, how common is for you to do ICG to make the diagnosis of VKH?
VKH, we make the diagnosis based on the clinical presentation. Imaging methods add to us to confirm the diagnosis. More importantly, more than the diagnosis, the imaging method helps us to monitor the response to treatment. For example, whenever we have an exudative retinal detachment associated with hyperemia of the disc and anterior uveitis spillover inflammation, the diagnosis of VKH is obvious. Most of the times they start with posterior segment inflammation. They may not have systemic findings. Vitiligo, poliosis and those things can develop in the later part of the disease. When we do FFA and ICG, they have a characteristic like multiple pinpoint hyperfluorescence with late pooling of the dye with disc leak in acute stages. When we do combined FFA and ICG shows more hypofluorescent or dark dots. It shows more extensive involvement compared to fluorescein angiography associated with fuzzy choroidal vessels and leakage. That helps us to confirm.
And ICJ may even show those lesions in what Dr. Biswas is referring to, sometimes unilateral cases. But when you do ICG, you find the other eye also has some dark spots.
Inflammation.
So in VKH, we don't call it unilateral unless we have ICG and the choroidal thickness on OCT of the opposite eye. So Anirudh, question to you. Very commonly, a young man comes with the exudative detachment in the posterior pole. Then headache, may not be there, and you are confused. Is it CSE? Is it VKH? Because one, you have to give steroids, other you don't have to, and you don't have fluorescein available. What will you do on OCT?
So when you have a macular lesion with an exudation, there are three possibilities really. One is it could be a VKH or it could be a granuloma, and third it could be CSC. Now on OCT, if you find that there is a big bump in the choroid with elevation of RPE and subretinal fluid, then of course it is a granuloma. If you have a lot of septae in the subretinal fluid or compartmentalization of fluid, so now we've called it as bacillary layer detachment, that goes in favor of VKH. But if you have a picture on OCT where you have pigment epithelial detachments, so you have PEDs, subretinal fluid, but there is no compartmentalization of fluid, and choroidal thickness is something that you cannot depend on. So if you have only these signs, it is most likely CSC. In both VKH and CSC, you will have choroidal thickening. Of course, fluorescein and ICG are very useful to distinguish between the two. But if you have OCT, compartmentalization of fluid, I think is very specific sign which differentiates between VKH and CSC.
So Reema, suppose like Anirudh and Padma have shown this is VKH. How would you follow this patient? Any investigations or treatment?
No, once you confirm it is VKH, we straight away start with IV methylpred. And the only investigations that we need are to start these patients on immunosuppression. So we do a complete blood profile, LFTs and RFTs, chest X-ray. So that is the only thing, and we admit these patients because we have to give IVMP. So usually IVMP is given for 3 days, max 5 days, followed by oral steroids, 1 milligram per kg per day. And we start them on immunosuppression as soon as possible once we get the clearance with the tests.
So now the last leg of pan-uveitis, Mudit, what will be the patients you would plan immunosuppressions or biologics right in, like you see the patient and you say go for biologics or immunosuppression?
You do have to give immunosuppression to these patients. These are patients who will need steroids for at least a year. Any patient who is receiving steroids for long term, you can't keep them on steroids forever.
And Behçets.
And Behçets, exactly. Though Behçets, so I was coming to that. Behçets probably will be a group where probably I'll directly start with biologics rather than just conventional immunosuppressive agents. So VKH, sympathetic ophthalmia, these are patients where I will probably start with mycophenolate or azathioprine. Azathioprine actually is my drug of choice. Though people have their own individual preferences, there are people who give methotrexate.
Somehow, I don't know, but in my experience, MMF works only with the very high dose, like 1500 milligram to 2 grams, it works very well. But in 1 gram dose or this, it somehow in Indian population, I did not. So azathioprine is our drug we use all the time, and methotrexate.
So my drug of choice usually is azathioprine. There are some patients who
easy to monitor.
Very easy to monitor. Yeah.
Labs are not too many.
There are some patients who sometimes come up with some adverse effects with azathioprine. Some of our patients have come back with alopecia. Some of them come back with altered LFTs. These are patients whom we have shifted to mycophenolate. But otherwise, we end up starting them with azathioprine. For biologics, my usual first indication is Behçets. If it's Behçets, I usually, if the patient can afford it, cost again becomes a bit of a problem, at least in our population. But otherwise, if the patient can, then we usually end up starting them for Behçets, at least with biologics.
So we will not talk about biologics here, Manisha. Second last maybe. You decide the patient on azathioprine like anybody can, VKH. So what would be the test you would do? How would you start and how would you monitor?
Test, is there anything specific, ma'am? I would...
Any lab would you like to do for toxicity or anything, or would you just go for the stepwise dosage?
I think for azathioprine, of course, you have to do a complete hemogram. You have to do a liver function test.
TPMT?
TPMT, yes. If the patient can afford, then we can do a TPMT. It is recommended, but sometimes because it's a costly test, we sometimes skip doing a TPMT.
TPMT is a test which will show you whether patient is going to show reaction or adverse events to azathioprine.
And especially a bone marrow suppression is something which these patients present, and sometimes if the patient has an adverse event in the form of bone marrow suppression, it can be really disastrous. So TPMT helps you to identify the patients who are going to be prone to that. Usually azathioprine, you start with 50 milligrams per day and you monitor the tests, and gradually you can go up to 100 or 150 milligrams per day for the patients.
So if we cannot do TPMT, which most of us are not able to do, we start with 50 milligram, call the patients after 2 weeks, ask the patient to come with LFT, hemogram. If there is no change, everything fine, you can escalate it to 100 milligram. And one last question, Dr. Biswas, what are the situations the patient, you have started on treatment, patient is not responding, what should a comprehensive ophthalmologist do?
I would, patient is not responding, and I would refer to a center. Where is that?
That's very important. I think that's the carry home point, that for...
Because it's a vision threatening disease.
Yeah. For all anterior uveitis, I think what this forum has said, nobody has talked about any fancy investigations, very basic clinical acumen. Start your treatment for intermediate, for posterior, even for VKH and others. Just start your treatment based on your clinical skills. But if within 2 weeks, 3 weeks, there are two situations. One, right in the beginning, it's a very atypical scenario. It doesn't fit into any typical phenotype. Just refer it immediately. The second is you are treating the patient, you expect a response, it's not coming, and you do not have advanced facilities available, then please refer the patient immediately. Do not start on a cocktail of treatment, because by the time many patients come to us, they are on anti-toxo, anti-TB, antiviral, steroids. So it's very confusing, because even if the patient is responding, you don't know what is working, which one to stop, which one to go. So I think in all these situations, it's very important to ask for help, because in uveitis, like Dr. Biswas beautifully said, that I'm still learning. There is so much we do not understand. So it's perfectly fine to pass on the buck to somebody else. So with this, on behalf of International Uveitis Study Group, I would request to thank all the speakers and the panelists for being there. And thank you, audience, for being there till 6 p.m. waiting for Aishwarya Rai Bachchan.